Thank you very much. So I'm Zach. I'm one of the acute med regs here, currently doing my respiratory block. I'm not a respiratory physician, but I know I can see we've got Dr. Malanas and Dr. Brown and Dr. Wilson will be joining us a little bit later. So they'll correct me if I veer wildly off into something that doesn't make any sense. But I've tried to lay this out in a way that I can understand it as a medical registrar, and hopefully it'll be useful for everybody else as well. So without further ado. So those of you who sort of have been working here will know that the acute respiratory unit setup does change and has changed throughout the last couple of years of the pandemic. The current setup that we've had, and this has been stable throughout my 3 months in the on the respiratory team, has been that we're only doing ARU, so only providing these forms of ventilation on 4 South. We've got FBay in the right-hand corner there, which has 4 red beds. They've sort of changed from blue to red, but at the moment they're red, and those are for COVID patients only. And we've got the 2 side rooms, which are blue, and that's currently where we can provide these things at the moment. The treatments that we offer, we've got sort of NIV, BiPAP, we've got CPAP, and we've got high flow nasal oxygen. And at the moment, really, the NIV and the BiPAP is what we're that's our bread and butter in terms of patients with COPD, with type 2 decompensated type 2 respiratory failure. And we've got CPAP and Optiflow, which we're offering some of our COVID patients. And I'll be talking a little bit more about that as we go through. But starting off really with NIV, because that's what most people will be familiar with. Certainly what I was familiar with using in these situations pre-pandemic. So this is what we're talking about. We've got the full face mask on the left of the screen there, which we supply CPAP or BiPAP, and we've got the Optiflow on the right there, which is the high flow that goes up the nose. I picked these photos mostly because I found them really funny. The fact that you've got this is very American. You've got these 2 people. The lady on the right looks like she's doing a juice cleanse or something, which is certainly not sick enough to require Optiflow. Our patients look very different from this, but they're the shiny high-res stuff that the manufacturers have on their websites. So that's what we're talking about. I'll start with an example case in the hopes that there's some audience participation, as Prof is encouraged. So let's imagine that you're the medical registrar in nights in this coming winter. You get a 75-year-old male who, with known COPD, presents severely breathless. His SATs are 88% on 6 liters. He's tachypneic. His PO2 is 8. His PCO2 is 9. So his PO2 and his PCO2 are the wrong way around, as it were. And he's acidotic. He's had treatment. He's had salbutamol. He's had ipratropium. I'm just keeping an eye on the chat as well. Can I please define type 2 respiratory failure? Yes, I will come on to that in a moment, I promise. So salbutamol, ipratropium, and prednisolone have been given. So he's had medical treatment in resus, and his chest X-ray looks a bit like that. So I suppose the question, particularly if there are any sort of registrars, SHOs, any trainees in the audience, would be what now? I'm going to go back and show you. So this is what we're dealing with. What would you feel like doing if you're in that situation clinically?
Are there any brave F1s who would like to unmute and say something? What should we do now? With these terrible gases.
Or if anyone wants to unmute and compliment me on the fact that I've spelled ipratropium correctly for the first time in my career, you know, that's also fine.
I can see Albert Ward. Can someone from Albert Ward? Here we go. Oh, someone's defined it. This is Amir has put in the definition.
Right. Well, if I can't encourage, there we go. So this is really decompensated type 2 respiratory failure, COPD patients who become acutely unwell and acidotic. That's really what we're looking for, and what we've always been looking for when we've talked about BiPAP. So NIV, this is ventilatory support that the patients receive via the upper airway via a mask or similar. Some of you might have seen the big hoods that they sometimes use in ITU. I'm not sure, Dr. Miles might be able to correct me. We've not used those, or we don't use those on ARU. We only use either the face masks that go over the nose and mouth, or the full face masks. We tend to use the full face masks. The advantage of doing that, as opposed to sort of invasively ventilating someone, so intubating them and putting them on a ventilator in an ITU setting, is that first of all, you avoid sort of instrumenting the upper airway and all of the issues that come about with that. You avoid sedation, which is obviously a problem in terms of that causes all manner of issues. The patient's able to interact and take meal breaks, so you're not knocking someone out and completely removing them from the equation. You can keep talking to them and you can continue with nutrition. And it avoids ITU and reduces the length of stay. Speaking as an acute med trainee who's done quite a bit of ITU, I would say anything that will keep a patient out of ITU is a good thing, because no one comes out of ITU without severe psychological complications and all manner of things that we weren't expecting.
It's okay. All right. And how are you feeling? You excited and ready?
I'll just mute that bit, don't worry.
It's not teaching in 2021 unless you hear a random conversation from someone in the audience. Key thing to remember about NIV, and I cannot stress this enough, and I'm sure the consultants in the room can't stress this enough, it doesn't treat the underlying cause, and we have to treat the underlying cause and maximize medical treatment, particularly when it comes to a COPD exacerbation. But also, when we say doesn't treat the underlying cause, I'll come on to the things that NIV isn't useful for in a moment. And the reason for that is if someone is in type 2 respiratory failure for any other reason, because they're incredibly drowsy, because they've dropped their respiratory rate, because they're intoxicated, NIV isn't going to reverse that underlying disease process. And that's really important to bear in mind. A little bit of a basic theory with, I think these are sort of Dr. Block's illustrations, which I really like. Essentially, when we're talking about type 1 respiratory failure, we're talking about, the oxygen is dropping, they're hypoxic. If we're talking about type 2 respiratory failure, we're talking about someone who's hypoxic and hypercapnic. This is all medical school sort of level stuff. I don't think, Prof, that we get any of the medical students in this session, to my knowledge.
They're all on holiday now. It's August.
They're all on holiday. Oh, it's all right for some. Yeah, so I won't go too deep into this. The key thing that genuinely took me years and years and years to understand was the fact that CO2 just seems to be better at diffusing than oxygen, and as a result, a significant VQ mismatch will make someone hypoxic, but really you need to be sort of hypoventilating, not getting CO2 out of your alveoli in order to become hypercapnic as well. So it's the ventilation that we're really interested in when it comes to type 2 respiratory failure. In terms of the physiology, when I say the only things worth remembering, it's because they're the only things that I can remember, is that the PO2 is proportional to the mean airway pressure and the fraction of inspired oxygen, by which I mean the percentage of oxygen that they're receiving. So if you increase those, the PO2 will go up to a point. But the PCO2 is inversely inversely proportional to the minute volume, which, as we know, is the tidal volume times the respiratory rate. So how deep a breath they're taking and how many breaths a minute they're taking. That will really determine how much PCO2 is that there is in the system. And when we say inversely proportional, we mean that the greater the tidal volume, the higher the respiratory rate, the more CO2 someone's able to blow off. So in these patients, the patient case that I discussed, someone who is hypoxic but also hypercapnic, really it's the minute volume that we want to focus on. We can't increase the respiratory rate, so really our focus is on increasing the tidal volume. And that's just to illustrate that these are the things that we can affect. We can affect the airway pressure, the FiO2, the tidal volume. We can't impact the respiratory rate. So that's why NIV is not a treatment for someone with a respiratory rate of 5. Some fancy graphics that Dr. Block puts in here. So you can see with NIV, for those of you who've used it before, which I'm sure is most people in this group, you've got the higher pressure, which is the IPAP, the inspiratory pressure, and the lower pressure, which is the EPAP, the expiratory pressure. And it's the difference between these is what helps you generate your tidal volume. Well, not generate, but increase and improve your tidal volume. So it's the difference between these two numbers that really helps us improve someone's CO2. Oh, okay, there we go. There's more animations. That's neat. Didn't think that was going to happen. There we go. So the IPAP minus the EPAP, that's your pressure support. And that's the thing that improves your tidal volume and your minute volume, and therefore drive that CO2 down. The PEEP, EPAP, that positive end expiratory pressure, that just maintains the pressure, helps sort of improve alveolar recruitment and improve your mean airway pressure, which will improve your oxygenation. For lack of the sort of more advanced physiology that was always a bit beyond me in medical school, MRCP, and thereafter, I just tend to think of it almost as if the CPAP is pushing open those airways and just maximizing the space available and the pressure available to get oxygen across the alveoli and into the blood. So with that in mind, if we want to improve oxygenation, we want to either increase the oxygen that we're giving someone, or we want to increase that EPAP. If we want to improve the PCO2, then we want to increase the respiratory rate, which is not something that we have control over, or we can increase the tidal volume and the pressure support. So increase the difference between those two numbers. I'll come on to how we set that up and how we manage that in a moment. But I think it's really important, and certainly this is something that I've learned a huge amount about doing my respiratory placement here as a registrar, is that there are some really important things to think about before we start the non-invasive ventilation. And I like to think of this as why not, where, and what if. The first and most important question is this a good reason to give someone NIV? And there are sort of two things that Dr. Malanas has given me on this presentation. I've made one of them a much bigger font because really this is the bread and butter of patients that we see in blue ARU is acidotic exacerbations of COPD. But there are also patients with neuromuscular disease, chest wall deformities, obesity, hypoventilation syndrome, who might be chronically hypercapnic and have an acute exacerbation. But predominantly it's those COPD patients. Those are the ones who come in frequently. Those are the ones that we mainly look after. I think that would be fair to say, Dr. Malanas, is that's sort of the bulk of the patients that we would expect to be looking after.
I'd say that most of the evidence to do it outside ITU is with the COPD patients with a clear X-ray, as in no definite consolidation. So I think it's good to put it in bold and big font, because that's where we can make most difference, I think, outside of the ITU.
Yeah, and
you've also nicely explained why CPAP. Let me make sure everyone understands this, that CPAP won't work for this patient, because I think there's often confusion at junior level about when to use CPAP and when to use NIV. So that's nicely explained. You need a difference because CPAP won't clear any CO2. Is that right?
Yeah, so if I go back, you can see that, as I said, if you see where it says pressure support, it's the difference between these two numbers. CPAP, which I'll come on to when I talk a little bit more about COVID, is a continuous positive airway pressure. So that's just one flat line. And with one flat line, you're not generating that pressure difference that's going to drive CO2 out of the drive air in and out of the lungs and drive CO2, allowing you to create a diffusion gradient to get rid of it. So a continuous pressure is not going to do anything. I think the other key thing to bear in mind is as Dr. Malanas says, there's a decent evidence base, for using NIV outside of the ITU setting for acidotic exacerbations of COPD. And I'll be coming sort of onto the evidence base or the lack thereof when we talk a little bit about COVID. Why not in terms of contraindications? So there are some absolute contraindications, which, as I said, I don't think we tend to see with St Mary's down the road. We don't tend to see too many burns. This isn't stuff that we tend to get involved with as physicians. It's the relative contraindications that are really worth thinking about. So patients, and essentially is this person so confused and agitated, drowsy and delirious that they're not going to be able to comply with NIV or really benefit from it? Or are they so sick that really sticking them on NIV is not the best option for them? This is someone that needs ITU. And I certainly think with the point of view as a medical registrar, being able to say, no, this is someone who's profoundly acidotic, with a very, very low GCS, who's very unwell, who looks like they're, imminently tiring. Often ITU will push back and say, well, actually, could we consider, trialing NIV on a patient like that? And I think it's having the confidence to say, no, actually, if someone's that sick, that unwell, we either need to say, actually, what is their seeding of care? And if they are for ITU, that's the point where ITU should get involved. So this is very important, particularly for sort of some of the trainees who just joined the trust. Outside of ITU, the only place that we're going to be delivering this is on ARU. And if there isn't a bed available, either a blue or a red bed, depending on that patient's COVID status, then that patient must go to ITU to receive that treatment. So in view of the sort of aerosol generating nature of this and the fact that it's, we can't be transporting patients through the hospital on NIV machines unless we're going to aerosol the entire lift shaft. We really want these patients to be having a NIV on ARU or ITU or not at all. And what if? I think this is again something that was always drilled into me coming up through training, and certainly something that we're that are really important for these patients is we shouldn't be starting this without a clear ceiling of care. So we shouldn't be saying, well, let's trial some NIV and then see where we're up to and then consider whether or not to intubate. We need to be making decisions as to whether or not we're starting someone on NIV as the ceiling of care, or whether or not, if they fail their trial of NIV, they be considered for ITU. And that's a really important discussion to have before starting it. In terms of how to make this happen, and Dr. Milanos, jump in if I'm missing anything, I think the key thing is in hours, these are the sort of patients that the respiratory team want to know about, and the sort of patients the respiratory team wants to know about early rather than late. So please do believe it'll either be me or someone who's an actual respiratory trainee, believe it or not, on 8248. Please contact us early if you think this person looks like they're going to need NIV. Don't wait till sort of when they need it. We'd like to know about them early so that we can get involved and help navigate this process. But really, it's out of hours where this might be a little bit trickier. And this is sort of the stepwise approach. First of all, we need to know their COVID status, whether they're red or blue. The majority of these patients will be blue. Although I'm not sure, during my time, I don't think we've had, correct me if I'm wrong, any patients with exacerbations of COPD who also coincidentally have been COVID positive. I've not come across anyone meeting that description.
I think I've had one
Mm.
in the second wave. I can't remember if they didn't do, I don't think they fared very well.
No, I can't imagine that they would.
But
But
I will
obviously,
say, really oddly, in both COVID waves, COPD seemed to disappear. I mean, you know, COPD was everywhere before, and I don't know why that is. It's strange.
I think maybe it's because of lockdown and less exposure to viruses, but I don't know if that's the whole reason.
yeah, definitely. I remember in the first wave, us wondering where all the COPD patients had got to. But I guess if you're not being exposed to any sort of, to anything because you're locked up at home and shielding, maybe that does reduce the risk. But anyway, it's important to know their COVID status. You know, we need to know that before we can get someone in. All ARU admissions need to be approved with the medical consultant rather than appropriate. It's a typo, but approved by the medical consultant. My understanding is that currently there's no respiratory consultant on call overnight, and the way that this wave is going, that seems unlikely to come in. So it does need to be discussed with the medical consultant. And for other med regis like me, that does mean waking someone up. Sorry, Dr. Brown, you oh,
there is a respiratory consultant overnight, Zach.
Yeah.
There's a respiratory consultant on call overnight at the moment.
Oh, is that okay?
But phone advice.
Yeah, and at weekends.
Fine. I didn't realise. So, are we waking up the respiratory consultant or the medical consultant to discuss these? So we can be very clear.
So if it's in hours, then it should be consultant to consultant. If it's 3 o'clock in the morning and it's clear that you need to speak to us rather than your take consultant, then you should speak to us.
Fine. Thanks. Sorry, I think that's I'm going on out of date information. Sorry about that. So once that's been agreed, I think the key thing is to explain NIV to and agree sort of the plan with the patient themselves. So I think it's really important to explain, so the patient, when they do get up to ARU, they're aware of what's going to happen, they're aware of what NIV is like, and they're not surprised when someone comes at them with a mask. So I think talking to them about that, some COPD patients who've had it before and have had bad experiences may refuse it. That's not a problem that I've had recently, but it's certainly a problem I've had in the past. And obviously with joint decision making, it's really important that conversation is had before we move them up to an ARU bed. Site manager is sort of the best person to speak to in my experience overnight to discuss whether or not there are any beds available in ARU, and they can help arrange transfer and make sure that the appropriate nursing staff are available with the right training to deliver this. I'm not going to talk too much about how to actually physically start NIV during this talk, but if anybody is interested in learning or getting skilled up from a medical point of view, I don't know, Dr. Milanos, if there's any opportunities for people to upskill in that if they want to do.
At the moment there isn't, but I haven't organized anything. I'm doing a talk for ED on Wednesday, but if anyone wants to come and have a play with the device, then let me know. You can email me and we can organize a session. And we can do it as, I know we do it usually as part of the teaching for anyone who's in the respiratory department, and I tend to bring a V60 machine over. So if anyone wants to do that, just send me an email and we can try and organize some dates.
In my experience, it's much easier to actually learn by, rather than someone talking to a PowerPoint. I think just getting hands-on and seeing how the kit works is the best way of doing it. In terms of the most important stuff as the doctor looking after this patient, sort of is all the necessary documentation is complete before the patient starts. And I'll talk through what the documentation is and where it can be found in Cerner in a moment. We tend to be repeating ABGs at 1 hour. I'll be talking about how to adjust settings off the back of that. We then need to repeat ABG 1 hour after any settings are changed. And that process tends to get you through to the morning when sort of the respiratory team are then in the building and can take things from there. In terms of the documentation, because this is the really key thing from our point of view, the 3 things to bear in mind are the care bundle, which is you can find under ad hoc. I've got a screen where I'll show you that in a moment. The NIV prescription itself, these are the settings that we would recommend starting someone on, and just making sure that's prescribed as you would prescribe any medication or as you would prescribe oxygen on the drug chart on Cerner. And then it's really important to sort of write some documentation, just include a note, including the results of any ABGs, any discussions that have been had with the patient, and documenting the initial settings so that it's all in black and white on Cerner and can be read by the team the next morning. In terms of that care bundle, so as you can go to ad hoc and it allows you to fill out all of this. And this really does just talk about all the things that I've talked about, just encouraging you to think about that you're doing it in the right place, that you've had the right conversations about their scene of care, about the treatment that they want, and that you prescribe the NIV. And here's how you find that on Cerner, is just go to the patient record, ad hoc, so under medics, non-invasive ventilation, and click record. And it's all really important that that's all done and sorted before the NIV starts. So keeping it simple for simple doctors like me, if patient is tolerating the treatment and their gases are improving, then continue. We can come in, if the respiratory consultant is in the next morning, they'll be able to tweak some of those settings and make a decision about what happens next. I think the difficulty, and certainly the thing that I've struggled with as a non-respiratory med reg in the past, is what to do if the gas isn't improving. And that's really the most important thing, is to reevaluate clinically. So I've certainly been in a situation where someone's handed me a gas and it isn't getting any better, and it turns out the patient's taken the NIV off and hasn't been compliant with it. Checking for leaks, making sure that it's actually going in. The nursing staff on Full South, I think, are excellent at troubleshooting NIV and getting the patients comfortable. Consider repeating the chest X-ray if things are getting sort of unexpectedly worse. Weaning the saturations, so making sure they're in the appropriate sats range, making sure that you're treating them, because remember, NIV isn't a treatment. They should still be getting all the necessary sort of COPD treatment, or they won't be getting better. And that's the point at which you want to continue. You might consider changing the settings. And the key thing when thinking about settings is to remember this sort of basic underlying physiology, which is, if we want the oxygen to get better, we need to change the FiO2 or the EPAP. If we want the CO2 to get better, we need to improve the pressure support. And someone's just like, there's a helpful troubleshooting guide on the internet under NIV guidance. Yeah, I've not got that in here, but there's some really, really good stuff on the internet actually that talks you through step by step. And certainly at 3 in the morning, I need something that I can just read and that makes sense. I've got very little problem solving ability when I'm sleep deprived, but honestly, that guide is very easy to read. Clicking through. So as I said, the key thing is, if you do go up on the EPAP, you can go up on the FiO2 if you need to. You can also go up on the EPAP, but the key thing is, don't go up on the EPAP and keep the IPAP the same, because remember, that means that the actual tidal volume is less. So if your IPAP is, I've picked some random odd numbers here just to upset the anaesthetist. If you're at 15/4 and you go up to 15/6, so you've increased the EPAP to try and improve alveolar recruitment, your pressure support has actually gone down. So you need to increase the IPAP as well if you want to keep that pressure support the same. If you're not driving PCO2 is high, then you need to increase the pressure support. And that means increasing the IPAP to help sort of improve ventilation and blow some of that CO2 off. If they're both bad, if you want to improve the PO2 and the PCO2, then what you want to do is increase both, but you want to increase the IPAP more. Because remember, if you increase them both, by the same amount, so for example, if you were to go from 15/4 to 17/6, then remember that means the pressure support is unchanged. So if you want to improve the PCO2, the difference between them needs to be greater, and that means increasing the IPAP by a larger amount than increasing the EPAP. So that's sort of a whistle-stop tour of NIV, which I think sort of if you've I'd say a lot of us are probably certainly more familiar with than we were with COVID come December 2019. But now we sort of come on to the sort of CPAP, and I think I've got a raised hand. Can't see who that is, but
yeah, hi, it's Richard Turner. Great presentation so far. Sorry to interrupt. Just a quick comment. I'm sure Brendan might echo what I'm about to say, but when you presenting the starting pressures for NIV, I think as the trust guidance actually, yeah, as you said, does recommend sort of an initial pressure of say between 10 and 15 as the IPAP and 4 of the EPAP. But a key point is to try and increase that IPAP as much as possible over the next 10 to 30 minutes, because this is kind of one of the reasons why people fail treatments. It's been shown in national audits, which is not giving enough IPAP. So ideally over the first half an hour, you probably should be aiming, as a rule of thumb, about 20 for the IPAP with 4 for the EPAP, and then doing another gas, or doing the first gas after the pressures have been stable for about an hour. So the sort of lower pressure initially is just to get the patient used to the intervention, and then just to try and escalate it as quickly as possible.
Mm-hmm.
Thanks.
Thanks. And just also I wanted to say, then once the patient is stable, another gas at 4 hours, because we get audited on that as well. So, and like Richard said, if you go up to 20 kind of in the first half an hour, you're kind of saving the patient a number of gases as well. So you'll have the gas when you start off with, and then if you work your way up to say 20, and then do a gas within 1 to 2 hours, you're most likely to see an improvement by then. And then if they're stable, you can do one at 4 hours. And then by then we'll have seen the patient in the morning.
Right. Cool. So yeah, it's 1 hour after any changes, and then 4 hours once they've been stable. And that's normally enough, I would say, to get you through most night shifts, isn't it? And those gases are really useful, certainly when we come around to do the ward rounds to planning where we go from there. So coming on just from the NIV thing to talk a little bit about CPAP and high flow. So sort of just to put this into context, if this was back in November 2019, so in the before times, you had a 45, and this is based on a real case that I must have seen, I think about that in the early winter last year. Fever and breathlessness, SATs are 92% on 60% via Venturi, bit tachypneic. Again, a type 1 respiratory failure, or the equivalent to it, with a very high oxygen requirement, with a bit of a respiratory alkalosis, so blowing a bit off. And the chest X-ray looks a little bit like that. So I suppose the question is, what in November 2019 would you have done? If anybody wants to chime in and say.
Come on, anybody, say something. You saw that chest X-ray. Looks like a terrible bilateral pneumonia.
Mm-hmm.
Or you could type in if you're a bit shy too.
Yeah, feel free to type in, I'll read it out.
I'll probably escalate for an ITU review quite early, given she's 45 no comorbidities with significant consolidation and hypoxia, and just about hitting her target stats on 60%. I mean, you can consider pressure support, but at the same time, she's got potential to deteriorate quite significantly.
Yeah, I certainly, I think it would be fair to say, and again, the bosses will jump in if I'm correct, but if I were the med reg on nights back then and I saw this case, it wouldn't really be, I would have phoned ITU very, very quickly. And I probably would expect that patient to be admitted to intensive care. It's certainly not someone that I would have wanted to sort of manage on an acute respiratory unit. Would that be fair to say? Yeah, definitely.
Sorry, so it's type 1, isn't it? So it doesn't.
Yeah, there's no role for NIV.
NIV on the acute unit
Yeah.
for type 1. You could use CPAP, but kind of that wouldn't be safe on the ARU.
And I think in that context, in a young person with a bilateral pneumonia like that, I would have been profoundly uncomfortable with someone requiring 60% FiO2 sat on any medical ward, even if it is a respiratory ward. Flash forward to sort of January 2021, and you get this story, a patient presenting this, they've had an 8-day history of anosmia and breathlessness. They've got a background of type 2 and diabetes and hypertension. They're saturating at 95% on 60% via Venturi, with a rest rate that's a little bit up. Their PO2 on 60% is 10.2. Their PCO2 is 4. They're not acidotic, and their chest X-ray looks a little bit like that. So with that in mind, if you were a medical registrar on nights, as I was, and will not forget in January 2021, and you saw this patient with these sort of results, what sort of treatment would you be considering for them, if anyone wants to chime in on that front?
Go on, Manish. You did it before. Have another go.
Well, it looks like he's heading towards possibly needing CPAP. Again, he probably needs an ITU review just to kind of cast an eye given his oxygen requirement. But he's someone I may want to consider for CPAP and have a chat with the rest of the consultant.
Yeah, and definitely, I think that's certainly what, why I was, I think, phoning up Dr. Turner about 3 or 4 times a day when I was on call back in those fairly unpleasant, the peak of that second wave. I think again, this brings back to that basic physiology that we talked about, and it's not changed. Remember that most of these patients have type 1. Almost all of these patients have type 1 respiratory failures, and that means the only thing we can really do is increase the FiO2, and we can increase the FiO2 to a certain degree without just with Venturi masks. So we've already done that by taking that person from 21% room air to 60% via Venturi. It's whether or not we also need to increase their mean airway pressure, and what treatments we can offer from an ARU point of view. But this is the physiology that we're trying to impact. The key thing before we get into any of this, and I'm sure that the the consultants would echo this, is that unlike home NIV for OSA, or home CPAP rather for OSA, unlike acute NIV in hospital for COPD outside of the ITU environment, the evidence base for these kind of treatments for COVID patients with bilateral pneumonias outside of ITU, I think is nowhere near as good. Would that be fair to say, Dr. Mons? And I think the reason I mentioned that case back in November 2019, and I'll reiterate this several times, is that in the before times, these patients would have all been on ITU. They wouldn't have been in ARU receiving these kind of treatments. And the reason we're doing these kind of treatments is because of the volumes that we're seeing. And that's,
there's a raised hand, HR 269.
Oh yeah, go ahead.
Oh, hi, Kareem and Zach. It's Becky Hodgkinson. I think you're touching on this now, Zach, but I wanted to ask you and the respiratory team, particularly as you're talking about NIV and COVID, whether I'm obviously in January, I don't know where we were with Recovery RS, but I just wondered, there is very little data. Is there any helpful data from Recovery RS, which was the trial looking at basically NIV and high flow oxygen and versus normal oxygen therapy in COVID patients, as opposed to ventilation, I think is the broad summary for anyone who doesn't know. Does that help? Has that changed our practice in the last couple of months, or are we still kind of feeling, I just wondered if that changed our practice recently.
We're still, I think there's a headline only, and I'm loath to discuss it now.
Sure, no, that's helpful to know. I wondered if it was just like still don't know, right?
I think let's wait. I'd rather wait for the paper. to be published, and then we can discuss it.
Okay, thanks. It's helpful.
Just in terms of, I'll talk more Hutchinson about what we're currently doing on ARU. More sort of out of, we're giving this is our approach to take, rather than it being based on as robust an evidence base as we would like. But just to touch, essentially CPAP, obviously, both CPAP and high flow can give very high flows of oxygen. But the idea is that we're also increasing that mean airway pressure to improve that type 1 respiratory failure, to improve the PO2. CPAP obviously provides a pressure of about 10 centimeters of water, but high flow nasal oxygen, because of the high flow rates, also gives a degree of peak as well. In general, and consultants, correct me if I'm wrong, we're trying at the moment to start people on CPAP, and then considering high flow nasal oxygen for people who can't tolerate that. Would that be a fair way of summarizing our current approach? Yeah, so as I said, we would recommend, if it is out of hours, that these patients, these COVID patients who, having had their ITU review and been discussed with a consultant, are being admitted to ARU, that we first attempt to start CPAP with a pressure of 10 and an FiO2 of, broadly similar to what they were having off CPAP, with a view to them weaning that down to maintain SATs in a target range. And for patients who really do struggle with CPAP, we've got high flow nasal oxygen, both for breaks for meals, which is predominantly what we're using it for upstairs at the moment, but also for those patients who just don't get along. I think the key thing is, and this is something that we're doing a lot of, is having conversations with patients who we're sending up to ARU and talking them through why we're doing what we're doing and what we're trying to avoid. So I think if patients know that they're going to be put on CPAP, here's what it's going to feel like. There's going to be a good nurse looking after them. But the aim is to avoid them needing invasive ventilation, so being put on a breathing machine in the intensive care unit. I think when those conversations are had early and patients are introduced to it in the right way, compliance is much better. I don't know if there's any evidence specifically to back that up, or if that's just something that we found, Dr. Milanos.
I don't know. I think it's good practice, isn't it?
Yeah. But anecdotally, we know that patients where someone's talked them through it and introduced it to them, and they're aware of why we're doing it, certainly in my experience, tend to get along a little bit better with it. So yeah, remember, just there is very limited evidence for this. This is not something as robust as we'd like it to be. These aren't treatments for COVID. They're not going to get someone better. They're just going to sort of help them continue oxygenating while they fight this disease. And just to say, we are essentially offering ITU level care to these patients in ARU because of the high flows of oxygen that they need. And I think that's always worth bearing in mind, that there's nothing about this that's ideal. We've got those 4 beds up there and we're trying to use them as best as we can. But it is essentially it's a tricky situation to be in. Key things to consider before getting someone to ARU is obviously, as I've said, does this patient actually need ITU? Patients who are in extremis, certainly some of the patients we look after, I've already said that they're ideally been on ITU. Patients who are really, really unwell, likely to need intubation. That's not something we can offer on ARU. And having someone who needs to be intubated as a crash intubation on 4 South is really not ideal. So if the patients are heading that way, even if they're going to use CPAP as a stopgap measure to bridge someone to intubation, that needs to take place in ITU. Does this patient have up-to-date imaging? This is certainly something to bear in mind, that if the patients are coming up and being put on CPAP, the point at which we can get a high resolution CT to look at the extent of lung damage and to rule out a PE has passed. So if you're thinking, we think this person needs to go to ARU, that's the ideal time to get some up-to-date cross-sectional imaging. Have we optimized medical treatment, of which, as we know, there is sort of a woefully limited amount available and proven for COVID? And is there an appropriate ceiling of care in place? When we started using CPAP at Barnet, where I was in the first wave, way back in 2020, sort of March, April time, we were only using CPAP for patients who would be for full escalation. Anyone who wasn't for full escalation wouldn't get CPAP. That's no longer the case as far as I know here, but certainly most important thing is that we've discussed their senior care and we know which direction they're going in, because we then know if we're trialing CPAP for someone who or Optiflow for someone where if it didn't work, we'd be calling palliative care and finding a way to make them comfortable, or whether this is someone who we'd be calling ITU for and getting them up urgently to consider intubation. So I think, as with NIV, there's sort of a broad similarity here, which is that senior care must be in place before we start thinking about these treatments. And then in terms of how to make it happen, it's broadly similar. I think first of all, we need to confirm the patient has COVID. That's very important. Again, confirming the IU admission is appropriate with a medical and respiratory consultant, explaining things in advance, ensure all necessary documentation is complete, and review after you've established treatments. But we're not routinely doing gases on these patients, as far as I know, Dr. Milana's, because it doesn't necessarily change our management. We're titrating to the saturations range, and if the oxygen requirement is going up, and sort of that's the point in which we might think about getting ITU involved. Would that sort of?
I think you probably want a gas to start off with, won't you, to make sure it's type 1 or type 2, and then once you've sorted that, you've settled them on high flow or on CPAP, then you can probably go by SATs, assuming that's the SATs probe meters working and all that. ITU will kind of ask for gases more frequently than we would, but I'm not convinced that that's needed.
No, so certainly, I should have said that obviously an ABG is needed to exclude a type 2 respiratory failure, but we're not ABGing these people as frequently as we do our NIV patients. We're tending to go by a SATs range. But obviously, when you call ITU, in my experience, the first thing they ask for is normally an arterial blood gas. But
I think it's mainly because they like looking at the PO2. It kind of like worries them a bit more, I think, when they see a PO2 below a certain value, but I don't think it's needed. I think we're in our right to challenge them as well.
Yeah.
And why would you want a gas?
Yeah. And I think certainly if someone's on, say, 35%, on the CPAP and seems to be improving, versus someone who's requiring 70% by the CPAP and tends to be getting worse with the rising respiratory rate, that is very important. So this is less common scenario, but type 2 respiratory failure, COVID, ward-based senior care, would you try BiPAP? I think the key thing to bear in mind with this one is, I think if they've got severe bilateral pneumonia and they are developing type 2 respiratory failure without a history of COPD or chronic hypercapnia, my feeling would be, and Dr. Milana's, I'll hand over to you in a second. My feeling would be, in that situation, you're looking at someone who's profoundly unlikely to survive, and I guess it will be a judgment call as to whether or not you think, BiPAP is sort of a good call for someone approaching the end of their life. I would be inclined to think with bilateral pneumonia that it's not.
I think, you can't put a one answer, I guess. It's an interesting case. I've never come across someone who's had COVID so far and had type 2 respiratory failure unless they've had underlying kind of chronic type 2 respiratory failure, and mainly it's been in the obesity hyperventilation population. That's when I've seen it, and I had one who was on home CPAP and had type 1, and she was obese and did actually well on CPAP. I've not, the ones we have tried it, who've had type 2 respiratory failure due to OHS and then developed COVID. Interestingly, I think she switched on to type 1, but we did try BiPAP. She deteriorated fast, but
is it about a junior doctor?
Keep an open mind would be my answer, and kind of manage expectations as well. I mean, type 2 COVID and ward-based ceiling would probably have a very poor outlook, so I would discuss it with one of us, and but
I think how much have we got? There we go. So essential documentation is broadly similar. We seem to be starting most people on a CPAP of 10, and we're rarely up titrating in my experience. I don't know. We've gone up to 12 a couple of times with people, Dr. Malanas, but I don't think it's not the same as NIV where we're constantly messing with it, as it were.
Yeah, I think one thing as well I'd like to mention is it's not always well tolerated. It's not a comfortable treatment. So when you're having patients, especially with COVID, who are hours on end on CPAP, then it can be quite uncomfortable. So that's one thing to bear in mind. And feels a bit like people putting their head out of a motorway, driving a car with the window down, it feels that sort of pressure. So to do that like kind of 12 hours at a stretch or more is uncomfortable. So yeah, so I think probably 10, beyond 10, I start getting a bit anxious and want ITU to come.
Yeah. And one last example case. So let's say, it's back in February, you've got a 30-year-old female, 9 days of cough. Her SATs are 82% on 15 litres via non-rebreathe. Respiratory rates up to 40, and she's a bit hypotensive. Gas shows that she's got a PO2 of 7.3, CO2 starting to come up. I guess what would to anyone in the audience your response to be there? Let's say we're in resus. Any takers as to what?
Prone and fast deep anesthetics.
Yeah, I think yeah, absolutely. So I think again, this is just is these patients where they're clearly just in extremis. So this is someone who we're not getting into a SATs range on sort of 80-90% oxygen. These aren't the sort of people who should be coming up to ARU, because this patient clearly needs to be intubated before they leave the department. So yeah, absolutely, that's not the sort of patient we want to see on full SAL. And I think that's everything from me, unless there are any questions. Something look in the chat. Yeah, cool ITU, everyone's cool. All right, everyone seems to have got that point at least. Yeah, any questions for us on that, or anything I've obviously left out?
I want to say, even if the patient is not for ITU, and say in the troubleshooting, you've kind of gone through everything and you're not sure, that there are ITU available. They can, if you're not sure about the NIV machines and you want another pair of hands or another set of eyes, then you can always ask, like, what's going on? Do you think it's the pressures, or do you think when you're on call, or do you think it's the pressures or the mask, or if you want help, don't be ashamed to ask for help, is what I wanted to mention. And one other thing, just think of things where you might come across kind of like certain scenarios which are difficult. You might not have the gases, or you might not. It might be a patient on the ward. Like once we had a case where we had a lady with MND, and she was deteriorating, and people didn't do a gas until the early hours of the morning, until the following day. So she just came in for a PEG insertion, and then had some opiates, and was getting increasingly drowsy. And I think it was neurology who didn't quite realize, perhaps, and neurology Jean looked at and perhaps appreciate the risk of CO2 retention. So always think about is that a cause for CO2? Is the deterioration of CO2 retention? So yeah, think of doing a gas and then escalating as appropriate.
Any other questions? One more.
Hi, Zach. I was just going to say, obviously within respiratory medicine, there was initially a huge amount of anxiety about the best way to treat patients with COVID, particularly at the start of the pandemic, and it's still not entirely clear, and there are no clear guidance anywhere. I think it's been alluded to already about which patients you should try NIV, or not. Sorry, I shouldn't say NIV, CPAP or high flow nasal oxygen in COVID. But I think a key thing is just for us, at least in respiratory medicine, is just having a very clear, frequent dialogue with ITU about these patients who are extremely sick. And a big role actually of ARU, which maybe has not been mentioned already, is stepping patients down off ITU, patients who've been intubated or patients who are still needing quite a lot of oxygen, people with COVID, so after they've passed their peak of their illness, but still need some probably intensive respiratory input and monitoring. So yeah, and different hospitals probably do different things differently. So it's very difficult to make hard and fast rules about the optimum respiratory interventions in patients with COVID.
Graham's got his hand up as well.
Yeah, it was just, thanks, Zach. That was really, really good. CPAP isn't ventilation. If you stop breathing, all you'll do is blow pressure into the patient. It's not going to ventilate them in the way that BiPAP does. There's no pressure support there. What CPAP does do is it probably changes the compliance curve and makes the work of breathing easier for patients. So you might remember that your lungs are made up of lots and lots of little spheres, and spheres have a tendency to want to collapse. We have surfactant which helps to reduce that. But unfortunately, surfactant can get damaged in conditions such as this. And maybe what the CPAP is doing is by holding the lungs at a slightly higher FRC and reducing that work of breathing, it's sort of buying the patient's time until the underlying treatments for COVID or their own body's response to the COVID actually gets them over it. So I think one of the things that as has been mentioned by my colleagues, is that we were slightly unsure about using CPAP. And I think even now, we would like a lot of these patients to perhaps be stabilized in the intensive care unit and then to come down to us when they're better. But it's quite often the case that they are coming to us, perhaps because ITU is so busy at the moment. So CPAP may well have a role to play, particularly for overweight patients, particularly for patients who aren't breathing particularly efficiently, by trying to get the patient's FRC improved, try and get their compliance improved. But yeah, I think we just have to remain guarded. And if anyone's not sure about the patients, to just, we are here. We're here at night as well. We're here at weekends, and we're certainly here during the 9 to 5. So please do call us and discuss these patients with us.
In the chat, thanks very much.
You're at 1,751 so far. Last week was 300, so I need 10K, guys. Okay, 10,000. Bit of a way to go.